Ladies and gentlemen, welcome to the program Health Easy TCO Employer Webinar Series Day 3. For this webinar, attendees will be in listen-only mode. If you need technical assistance, please submit your request under the Tech tab in the window in the top right-hand corner of your computer screen. If you wish to submit a question during the presentation, please use the Q&A window in the top right-hand corner of your computer screen. Presenters will do their best to answer your questions. However, due to time constraints, not all questions may be addressed during this webinar.
Good morning, everyone. Welcome to our third and last webinar in our series for employers on value-based care, co-hosted by Twin Cities Orthopedics, our longtime valued client. We've had great feedback on the first two webinars, and if you missed either of those, let us know and we can send you the recording. Today, we'll look behind the curtains further to delve into how providers are paid, differences in site of service, and get into some simple plan design changes that can be made and employee incentives that actually work. It is now my pleasure to introduce our panel for today. First up is Troy Simonson, who many of you here in the Twin Cities know. Troy currently serves as CEO of Revo Health, who's dedicated to leading the value-based care revolution. Revo helps medical specialty practices design and build value-based care solutions for their clients. Prior to this, Troy served as CEO of Twin Cities Orthopedics for 16 years. Next, we'll hear from Chip Burgett, who is Senior VP of Payer Partnerships at GlobalOne Ventures. Chip is a seasoned healthcare executive who's done pretty much everything in all aspects of healthcare. GlobalOne is a market leader in the development and operation of bundled rates for ambulatory surgery centers across the country and has one of the largest networks with 150 surgery centers in California and expanding to other states. And our last presenter is our very own Josh Schreiner, Chief of Staff at Health Easy. Josh oversees our proprietary network, America's PPO, the first network in the country. And in addition to that, our operations. He'll talk about some plan designs that have worked for our clients using the Elite Network, which TCO and iHealth are both part of, and how we can easily administer value-based plans and set up clients so that we can actually steer members to the providers they need to see. So with that, I will turn it over to Troy. Thank you.
Thank you, Jeannie. Welcome, everyone. Appreciate people taking the time this morning to log in, and hopefully we can share some information here or little takeaways that each of you can take with your own health plan, or if you're a provider group, you're wearing a hat of a provider and a employer. So first thing, I want to just level set a little bit, as some of these terms will be used throughout the discussion here, to make sure kind of we're on the same page from a definition standpoint. So out of pocket, really meaning your co-insurance, your deductibles, co-pays, so the out of pocket costs for the actual individual. Plan member, commonly used term, but obviously is the employee or any family members covered by that employer sponsored health plan. So when we think of plan member, it's the actual essentially user of the healthcare. Purchaser, obviously in the discussion here where we're talking about a lot of self-insured employers, or hopefully future self-insured employers, where that purchaser is really the employer and or the plan member. So if a plan member has an out-of-pocket expense, they're a purchaser, as well as anything above that copay or deductible that actually the employer ends up paying is obviously the purchaser. Then we'll use the term provider in some instances, where really that's the healthcare service provider. But keep in mind that may be an actual physical facility as well. So when we talk about providers, it's physicians, ancillary providers, was it physical therapists, or et cetera. but actually the physical facility as well. Site of service will be a topic you'll hear a lot about. So the actual physical location where that healthcare is provided is a major driver of the cost. So whether it's a clinic, a surgery center, or a hospital setting, those factor into that overall cost of care. And then TPA, we love acronyms in healthcare. So TPA, or third-party administrator. I would consider Health Easy a third-party administrator, but frankly, as a self-insured employer, any health plan is essentially your third-party administrator, whether that's Blue Cross, United, Preferred One, Health Partners, etc. So I'll kind of bunch all of those into TPAs. Some I would identify more as an independent TPA versus a traditional plan, but we'll talk about that in a minute as well. So first piece, want to spend a little bit of time on what I'll just call the smoke and mirrors that happens in healthcare. We love to make things complicated in healthcare, which can obviously drive up the cost as we make it confusing for that plan member or the purchaser of the healthcare. But one piece to keep in mind is site of service. And I use just the typical dollar signs associated after it of a clinic or outpatient clinic, kind of a $1 sign. Next level up is as you get to an ambulatory surgery center, which would be $2 signs. And then if you were talking HOPD, again, another acronym, but a hospital outpatient department or hospital outpatient surgery, now you're talking $4 signs. So there's a progression that happens based on site of service as far as what it is costing that purchaser at the end of the day. And I'll share some examples of how, as an employer or a purchaser, that you can make some decisions that differentiates those areas. The other thing I will say with this is that the surgery center term gets used pretty freely in the market, and specifically it happens in the Minneapolis market, where something may actually be a hospital outpatient department, so $4 signs, but they actually call it a surgery center. So again, in healthcare, we like to create confusion. So it's a little misleading. So that's where you really got to lean on your TPA to make sure they're defining what truly is an ambulatory surgery center versus a hospital outpatient department. Because the name on the building may not be accurate on how it actually gets billed. Another thing you hear a lot about, likely in the market, is risk-based agreements. Frankly, a risk-based agreement, and I'll give you an example of one of these that exists in the Minneapolis market, is a payment that is purely based off of clinical documentation, not based off of outcomes of the patient. So the more documentation that provider has inside of their EMR, and the more essentially comorbidities that they can identify for the patient, the higher risk that patient is identified, which equates to higher payment ultimately to that provider, which creates higher cost to you as the purchaser. This is a very, I'll say, rudimentary example, but is basically how it works. Is an annual payment if somebody was, let's say they were in a structure for a risk-based contract underneath for primary care services. So that provider gets paid what's called a PMPM per month, per member per month fee, times the risk adjustment factor times 12 months to figure out their annual payment. The risk adjustment factor is entirely based on what is documented in the EMR, not based on outcomes, not based on that patient experience, based on what the physician documented in the EMR. So let's take a scenario of you had a patient that had the same individual patient and they went to see 3 different providers. First provider provided very limited documentation in their EMR. They maybe provided the best experience for the patient because they were focused on the patient and had good dialogue and spent some time with the patient, but they frankly just didn't document well in their EMR. The risk adjustment factor for that individual might be a 0.4. So you take the 0.4, times the $500 PMPM times 12 months, that provider is going to get paid $2,400 for providing that individual their care. Same individual goes to another provider. They document a little bit more. They had a couple risk factors, whatever comorbidities they might have had. They document that actually in the record. Now they're a 0.8 risk factor. Now that payment, 0.8 times the 500 times 12, now they're getting paid $4,800 for that same patient. Third provider they go to has been educated, is really good at documenting, hits on every single point that they can figure out with this patient. Risk adjustment factor just climbed to 1.5. Care didn't change for the patient overall. They were just a really good documenter. And I will, it's no secret, systems will educate their providers on how to document. So now the risk adjustment factor went to 1.5. Now the payment actually that is being paid, that the purchaser is likely paying, is $9,000. So same care, same likely outcomes for the individual, minimal impact on that quality or outcome, and ultimately the providers, the payment differential is significant. So those are some of the risk-adjusted, risk-based contracts that are out there. So if you're getting sold a risk-based contract, i.e. that the provider and the TPA has a risk-based agreement, make sure you dig into that a little bit further about, okay, well, what is the risk? Is it based on outcomes? Is it based on quality? Or is it just purely based off of documentation? If you're getting into an agreement where it's based off of documentation, you might not be able to control the cost, and your costs might escalate with no better outcomes or quality for your actual plan members. Another item that, again, we see a lot in the Minneapolis market is narrow network products. I'm not a believer in them. I'm a believer that patients need choice. A narrow network product really at the end of the day is to dictate market capture, is to dictate where that patient is going, to control the patient inside of the walls of a certain healthcare provider. So they may create a narrow network that the best plan benefit that individual can receive is if they stay inside of that system. If they go outside of the system, they might still have a benefit, but maybe their co-insurance or their out-of-pocket expense might increase. So again, stay focused on from a standpoint of what are you actually buying from that narrow network, and are you truly reducing the patient's choice? I think as human beings, when our choice gets stripped away from us, we lack engagement, and we'll just continue to follow along. We won't ask questions. We won't say, is there a better site of service that I could go to than where you're referring to me? Those are pieces to really look at from a narrow network standpoint. When you get into, we had a recent conversation with a large health plan, and I was very curious to see their response to this, but their response when I asked them about some of these narrow network products and what they've seen in a fully insured world as it relates to benefit to them as the payer or the insurance carrier, their comment here in quotes of seeing very little value in narrow network designs. They were specifically talking about an ACO type design, but saw very little value at the end of the day, and ultimately as the purchasers of the healthcare in that situation. That ultimately patients having choice and being educated on where, the right place at the right time with the right provider is more of the education that needs to happen ultimately. So focusing a little more, switching gears now on really looking at plan design goals and aligning incentives. And what can you do as a self-insured employer with your plan design? And ultimately, how do you create high value inside of your health plan? So when we talk about aligning incentives in this model, it's really focused on how do we align quality, experience, and financial incentives across the board. So when we think of the plan member, again, that's the actual employee or their family members. The purchaser, which in a self-insured model would be the actual employer and or the plan member, and then ultimately the provider as well. So how do we align those incentives across all three of those individuals or those individual stakeholders as it relates to receiving healthcare and then ultimately providing that healthcare as well, and different avenues that we can go as it relates to aligning those incentives. So what are some of the high level, what do you need to do, or what do you need to think about as a self-insured employer? And then I'll get into three simple, what I would think are simple takeaways that you can take with this. Is first and foremost, I would encourage people to look at broad network availability. Allow patients to have choice and engagement. You might have different tiers inside of that broad network where you're trying to educate individuals on where the better value is, but allow individuals to have choice. I think as you allow them to have choice, you will create engagement with those individuals, and they will start, quote unquote, shopping for healthcare, and they will start looking at better options, especially if you give them some tier levels inside of that broad network. Well, now they've got some choices that they can educate themselves on as well, and they don't have to create the tier themselves. There's some education that you can tie to it from a standpoint of your overall network availability. Have access to your data. Make sure whoever you're working with that you have access to your data. It will help you create your tiers as you go forward into the future. If you're working with whoever your TPA is today and you rarely see your data, find another TPA, quite frankly. I don't know how to say it any easier. Is if you don't have access to your data, you're never going to be able to improve your plan. Have the autonomy to pull levers in your plan design, and I'll talk about that here in a second, but that gets back at that point of finding ways to align incentives. That's going to be a simple takeaway you can look at, but make sure you can do it. There'll be some TPAs you work with that they have certain products that you have to purchase, and that's it. You have no autonomy inside of that plan design to kind of move things around. And so make sure whoever you're working with from a TPA standpoint provides that autonomy, that you can actually move some things around from a plan design. And then plan member education, I think that is something that has to just continuously happen amongst your plan members. So 3 quick takeaways. Review your network and TPA options. Going back to what I just talked about, do you have the autonomy to make some changes? Do you have your data? I would classify these in simple areas of traditional or independent TPAs. Traditional being, traditional health plans versus independent TPAs such as like a Health Easy, where you have a lot of autonomy and you can make some moves. Here's one simple question, and I know we probably have some brokers on the call today, respectfully stating this, is one simple question you should ask your broker if you work with a broker is, do they receive a retention bonus from their current plan? So if you're currently with Blue Cross, does that broker receive a retention bonus from Blue Cross if you stay with them into the next year? They're out there. They're there. Obviously, a little bit of a perverse incentive in some situations, but it's a simple question you should ask your broker if you're truly working with a broker on, do they receive a retention bonus? Short term, I get it. Changing a network creates a little disruption, definitely creates some disruptions in the human resources space. But long term, I think it absolutely adds value to you as the purchaser. Second takeaway, use plan design to align incentives and educate. Getting back to site of service, co-insurance amounts. Josh will go through an example of this here later. I'll provide an example here on the next slide too. Really simple levers you can pull inside of your plan design that focuses on educating the consumer or the purchaser, as well as aligning incentives. So a very simple thing you can do: hospital-based outpatient surgery versus ambulatory surgery center. A 40% co-insurance if you're going to a hospital, versus only a 20% if you're going to an ambulatory surgery center. I guarantee you, at the end of the day, the plan sponsor or the purchaser, the employer will save money even though it's a lower co-insurance from the plan member perspective. Same thing as you get into imaging. Is that imaging being done in a hospital base versus ambulatory center? Another thing that we have looked at even on our own individual health plan is as it relates to preventative medications. So even in our high deductible plan, we moved to essentially a copay model related to preventative medications and created a substantial differential related to generic versus brand name preventative medications. We want to make sure people are accessing their preventative medications, and we want to make sure that it's really easy for them to access it with a generic preventative medication versus at 125. Now, hopefully they create that question back to their provider or to the pharmacist of, is there a generic option that I can be looking at? It's going to save me over $110 on that prescription. So little simple things there that one, educate, and one, have people pause and ultimately ask the question. And then last takeaway, and Josh will talk about this as well, is start creating those preferred tiers. So this will come from the data that you have inside of your health plan, and you'll be able to start identifying, okay, here's high value providers, and here's providers that add value. So start creating that preferred tier. I'll call it network or preferred tier design inside your plan, still allowing open access for all of your plan members, but it starts to educate your plan members as well as relates to, okay, where is the value? Should I have this carpal tunnel done in a hospital? Should I have it done in a surgery center? Or should I actually have it done in a clinic procedure room? What are my options there? And there will be significant cost difference across in that exact example. So 3 simple takeaways, again, of look at your preferred, your tiering, look at your site of service, and really start asking questions with your TPA about what options do you have from a standpoint of changing co-insurance amounts or creating different tiered networks. Another really, really simple thing, not to get too far into the weeds, can you bid out your stop loss? Your stop loss insurance is usually your highest fixed cost. Many traditional plans don't allow you to bid it out or go to market with your stop loss coverage. Ask those questions, and it ultimately will create that better value into your health plan. With that, I will turn it back to Jeannie.
Great. Thank you, Troy. Well, when we said behind the curtains look, I think that really was some great information there in saying what is actually happening, especially in the Twin Cities and our market. It's really insightful. I think the part about getting the right care at the right place at the right time is something that we talk about all the time, and it makes a huge difference for the member's experience as well as the plan cost. So next, I'd like to introduce Chip Burgett, and he will get into more of what's happening on this front nationally, as well as plan design incentives that they've used. So we'll welcome Chip now. Thanks.
Gene, thank you. I want to thank Health EZ and Twin Cities Orthopedics for the opportunity to speak to you today. So the focus of the discussion is plan design, and I want to link back to the opportunity of bundle payments as a key in the value-based benefit design strategy. And importantly, to make bundle payment work, basically the importance of member engagement and plan design incentives to really drive patients, plan members to those bundle payments. Last week, Aaron Johnson talked about Twin City Orthopedics Excel program. I'm going to discuss GlobalOne's experience in California, Florida, and other states to provide some broader perspective in terms of the opportunity in bundled payments. So just a little bit of background on GlobalOne. We're a California-based company. We develop networks and do administration relative to bundled payments. Our focus is bundled payments in surgery centers. These are prospective bundles, pre-negotiated, focused on the surgery center, the ASC market. We've been doing bundles since 2009. We started out working with insurance carriers in California, have since moved on to working with self-funded employers, transparency companies like Healthcare Blue Book. Our California network, as Gene mentioned, is large. We're contracted with 150 surgery centers, over 1,000 surgeons, covering 80 unique procedures in the bundled payment programs. But bundles require innovation. And as we move forward, our focus is on the self-funded employer side, and importantly on third-party administrators that can help administer the important parts of the bundled payment. We think HealthEZ, by the way, fits that criteria. We're also in discussions with Troy and Revo in terms of how we might work together in the Minneapolis market and other markets. So some basics on bundled payments. I think a picture is worth 1,000 words, and basically buying a car a piece at a time is exactly how we purchase healthcare services. For each surgical procedure, we're buying each service individually. That ends up being very expensive, and indeed, we have no idea what the total cost is before we purchase that service. A bundled payment, of course, is basically a single cost that encompasses the surgery center, the surgeon, anesthesia, all aspects of the cost relative to that specific bundled rate. We focus on surgery centers. As Troy mentioned, surgery centers are much less expensive and indeed have better outcomes, and I'll talk about that. So with bundles, what we're trying to do is really create a market price, something that's comparable so that purchasers are able to compare cost and quality and create truly a shopping experience. Just as, kind of an example, think of hospitals and think of them in the car business. I would go to hospital A, pick up my Ford F-150, and I'd get billed $35,000. If I went to hospital B, I'd get the same F-150, except I might be billed $75,000. You go to hospital C, get that truck, I'd be billed $50,000, but discover that I had 100,000 miles on the vehicle and had already been in a wreck. This is how we're purchasing healthcare, blindly. Bundles provide really the insight in advance to help us know what we're going to pay. So from the plan sponsor perspective, essentially, you're going to know in advance what that price is. It's budgetable. And additionally, your plan members are not going to have any surprise billing. All the components of the bundle, the surgeon, assistant surgeon, surgery center, anesthesia, all the components are in the bundle. So no surprise billing relative to the plan member. As mentioned, surgery centers are much less expensive. If we look at total knee replacement, on average, a hospital bundle for all services might run average maybe $45,000. Our bundles for total joint would be about $25,000. You can see the difference in that. Additionally, surgery centers have significantly better outcomes and fewer complications. National data shows us that hospitals typically have complication rates of 3 to 4% of all patients. Surgery centers, the complication rate is 0.5%. So a significant difference in quality of care. So the value equation there is a better price, you know the price in advance, and you're getting better value. We bundle a fairly large number of procedures, as I've mentioned. And what we're really trying to do is maximize the number of cases. So we're contracting for orthopedics and spine, general surgery, which is bariatric surgery and hernia repair, women's health, gynecology, ear, nose, and throat procedures, cardiology. The idea here, again, as Troy mentioned, is shifting services from the hospital or the hospital outpatient department to surgery centers. As we do that, there's a significant downshift in cost and an opportunity for significant savings for the plan sponsor. Additionally, even for those procedures that might already be performed in surgery centers, like knee scope repairs and things of that nature, we're able to lock in price and confirm and hold price for a 3 or 4 year period. So bundles really operate for the plan sponsor, for the self-funded plan sponsor, to de-risk them relative to the cost of care. It's no longer an unknown. So getting to the notion of incentives, why offer incentives in your program? A simple example, and maybe an obvious one, back to my example, if we have a total joint case that might be $45,000 all in from a hospital, we're bundling at $25,000. If we assume a plan, just for simplicity's sake, an 80-20 plan that's got a $5,000 maximum out of pocket for the plan member, here's the math on these two. Basically, for the hospital, the plan member pays their 20%, maxes out at $5,000. The plan pays the remaining $40,000. Under the bundle, the plan member is also maxing out at $5,000. The plan, though, is paying $20,000, so obviously saving the $20,000. Well, an extreme example shows, though, that to really be able to drive interest in a bundled program across the board, there's got to be some level of shared incentives with the plan member. So the key to the program is really member engagement. Troy talked about this, and engagement is the important part of the program. Unless the plan member knows how to reach that provider, how to take advantage of the program, or unless the plan member has some help in identifying the opportunity, they will not take advantage of the program. They'll end up going to the $85,000 hospital for their total joint, and your plan will be paying the difference. So really critical that there's engagement, and incentives really help drive that engagement. Additionally, a couple of other issues that come into it. In a bundled program, it might require a change of surgeons. So I'm seeing a doctor, and I really want to go to the Twin City Orthopedic program to take advantage of Excel. I might have to change surgeons. That requires some inconvenience in terms of booking another appointment. It might require some travel if I'm in an outlying area. There may be a timing issue in terms of booking. I'm scheduled for my surgery next week. I might be booked out a couple of weeks. All these are reasons, in addition to really just the ability for savings, to help engage the plan member in terms of understanding how the program is going to work on an overall basis. So in terms of driving member engagement, what's going on in terms of the incentives that are being utilized for different programs. What we've seen across the board, what works the best is obviously the most, which is many programs basically waive deductible and copay and provide really a zero out of pocket for the bundled payment program. Others will use the problematic cases in terms of identifying which cases to identify for the benefit incentives, so that if bariatrics or total joints were a problem in terms of utilization, incentivize those specific procedures. So targeting services is one way to do it. Troy mentioned by provider type, where the benefit structure could be a lower copay for the hospital outpatient, a higher copay for the surgery center. Other plans do it on behavior relative to the plan member. If there's a utilization review program or an expert medical program available for the member use, and these are really steerage mechanisms to help guide the plan member to your bundled program, maybe a higher copay for those members or a higher deductible for those members who may not utilize the program. One caveat, obviously, is deductible waiver with some plan designs might be difficult. Obviously, check with your benefit advisor on that. Sometimes administrators have difficulty with multiple copay type programs. So we have seen other plan sponsors, other employers go to cash rewards, basically where the plan member utilizes the bundle payment. The benefit plan works the same, but there's a cash reward based on savings after the plan member has taken advantage of the bundle. I've got an example of this on the next slide. Others have, rather than use cash, others have used time off, where additional PTO is granted, additional 5 days, for example. This might work potentially with younger employees who are looking for additional time off. Disincentives can also work. Talked about some of the penalties potentially in terms of enacting a higher copay. Some programs have looked at using bundles really as a reference-based price. So the $25,000 total knee, if you go to Twin Cities Orthopedics, we're going to pay that $25,000. Indeed, if you go anywhere else, we're going to pay that $25,000. Now, this has to be rolled out very carefully, as we've seen with reference-based pricing programs. The plan member doesn't know a lot about the program, ends up going to that high-cost facility and ending up with a huge out-of-pocket, causing significant employee relation concerns. So last, just one of the examples of one of our clients. This is a company in Northern California, and the structure they developed. A little bit about this organization. This is a trust of about 6,000 employees in Monterey County, which is south of San Francisco. This is an area that has very, very high hospital costs, and this plan sponsor was looking to shift as many surgeries as possible to surgery centers. So what they came up with, and kind of over time, developed a strategy where not only were they waiving deductible and copay for all their bundled cases, they also created basically a cash incentive based on savings, as indicated there. So under $10,000, $500 cash, and so on. This is, again, reportable on a 1099. Now, what this did over a 3-year period for the 6,000 plan members, there were 486 cases that went through the bundled program. The program saved in 3 years $7.2 million, or over $15,000 per case. And that, again, for 84 potential cases. So that's averaging in the lower cost knee scopes and hip scopes, and averaging in the higher cost spine surgery and total joints. So an extreme example maybe, but basically a plan sponsor that fit their benefit to the needs they had relative to the costs in their marketplace. Just shows the example. Again, they had an administrator that was willing to structure this to make the program work for them. So that's the extent of my comments. I hope there's some questions as we're done, and I'll turn it back to Jean.
Great. Thank you, Chip. Great information again on what the true cost of care is and what you can do with your plan. We can probably agree with the high cost of hospital claims we've seen in California, and especially in that area you just mentioned. So being able to create these bundled payments and maybe not resort to reference-based pricing is definitely a strategy that employers can look at. So next, we have Josh Schreiner, and he will get into what we've done with tiered plan designs, which Troy talked a bit about. And from there, we'll go into the questions. So please submit any questions in the chat box. and we'll address those after Josh's presentation. Thanks.
Thanks, Jeannie. I want to thank everybody for taking the time today. I think this has been a fantastic conversation. And one thing that I would point out is something that's different about Health EZ when you're looking for somebody to administer your benefits is working with somebody who makes things easy. It sounds cliche. We often joke internally that we're not health hard, we're health easy. And some of the reasons for that, and we'll show on the next slide, is we want to take everything that you've heard today and bring it down into a digestible size. And so when you're looking at plan design and incentive, it's absolutely critical for steerage. So if you think about my wife as an example, I often will bounce ideas off of her as we're whiteboarding or thinking about new ways to engage consumers. And so my wife had an incident earlier this year, and she was in need of an MRI. And I asked her, if you had a price transparency tool at your fingertips and you saw that it was $500 for an MRI at one location and it was $1,500 for an MRI at another location that was not preferred or referred to by your physician, would you make the change? And she said, no, I wouldn't make the change. I'm going to pay the same amount, whether it's $500 or $1,000 or $1,500, because that's the way that my plan is set up. And I said, well, what if instead of thinking about the total price, it was $0 if you go to one location, or you had to meet your $1,500 deductible if you went to another location? And she said, yep, that makes a difference. So when we're thinking about plan design, and I'll go to the next slide here, the easiest way to incent consumers is to focus on their pocketbook. So we have created a elite network that iHealth uses that is focused and is driven on a couple of main components. One is cost and the other is quality. We have created an easy, digestible scoring for providers that rates them from an A through an F on specific services. And that is what we're using to determine who is in our elite network. But as you can see on a tiered benefit approach, in the example I just gave with my wife, if she went to, in this example, TCO for an MRI, she would pay nothing. If she went to a hospital to have that MRI, she's going to be responsible until she meets that $2,000 deductible. And when you start putting incentives in place that affect the consumer's pocketbook, it helps them to make the right choice. Another anecdote, one thing that was released last year by HHS was hospital price transparency. And that is something that I think a lot of brokers and employers are hoping will make a difference. And the purpose of that rule is for about 300 different services to be easily understandable and shoppable for consumers. And I can tell you right now, if you go and look at any of the hospitals that are near you, one, it'll be a challenge to find those pricing lists. Two, it'll be a challenge to find the commercial pricing lists. And three, it will not be in an easily identifiable or understandable phrasing. And so one of the things that we do at Health EZ when it comes to consumer engagement is we refer to things in plain English. So if you go in for an office visit, it says office visit on your EOB. It does not say evaluation and management or some other CPT or Medicare defined term. The other thing with pricing and price transparency is there are essentially proxy shoppers. And proxy shoppers are somebody like my grandma who goes to Costco, and in Grand Forks, North Dakota, she goes to Hugo's, and she looks at the price of a lemon and determines whether it's cheaper at Costco or Hugo's, and then she buys it at that location to save money. Most individuals do not focus or want to make 3 or 4 different stops in order to get their groceries. So they just go to Hugo's and they buy everything. Some things are higher, some things are lower. And so it's not necessarily going to produce healthcare decisions, because most people go where their provider tells them to go. So just to reiterate what everybody has already said today, and I think it's really, really important, is that incentives are what are key to get consumers to make the right choice. If you just have a network and you tell them you should go to Twin Cities Orthopedic for this service, but their provider told them to go to TRIA, and there isn't a financial incentive, it's going to be very, very challenging to convince them that they should move to a different site of care or to a different location for care. So how are we doing that? We are actually, and it's very exciting, are launching a brand new mobile application for consumers in July. And part of that is going to be a provider lookup tool. And then in a future state later this year, there will also be pricing and cost information. So one of the weaknesses with the price transparency with hospitals having to post that information is, one, the penalties are minimal. So a hospital to not post their pricing is a fine of $300 a day. So if you think about that over the course of a year for a $5 billion organization, it's not much of a financial incentive. So we believe it's really, really important that consumers have, outside of plan design and incentive, at the palm of their hand the ability to do cost comparisons and cost lookups. And if they have that information paired together with an easy to understand financial incentive, they are more likely to make the right decisions. And with that, I will turn it back over to Jeannie, and we'll see if there's any questions.
Great. Thank you, Josh. Again, great information. I've been very impressed, as have a lot of us, with all the content that's been presented as part of this three-part series. Just really great information that talks about true transparency, what value is, accountability, and what people really need to consider when your healthcare spend it could be your second biggest item as an employer next to payroll. And so I think everyone is willing to drill down and look at what can you deliver as true value, better benefits at a lower cost, which was, again, the premise of presenting this information to educate people. We do have a couple questions that we get to, and if you're not able to stay on to just one housekeeping item, we will be doing the drawing for the 2 Viking tickets later today. So if you attended all 3 sessions, you have 3 chances. 2 sessions, 2 chances, and 1 webinar, you have 1 chance. So we'll notify the winner of that tomorrow, and I'm not eligible, just again to repeat that. So a couple questions we have in here, and you can continue to submit. The first one, I think both Troy and Chip could probably answer, but are bundled rates for the same procedure different in different markets or states?
Well, I'll take a first swing at that. Our experience is that while there's some differences, they're really very close. And frankly, they should be close. The variation comes primarily from the technical side, or, it's either the hospital or surgery center side based on carrier contracts. But the professional components are very close. And indeed, as we look at, for example, total joint replacement state to state, the range of $22,000 to $25,000 seems very operable in terms of what a standard rate is. And this is really, in my mind, the strength of bundles, is that we now have a market price. If I'm a multi-state employer, I can use that, look for quality differences amongst providers, and make choices based on that kind of information.
Yeah, I'd agree with that, Chip. And the only other piece I'd add to that is what is in the bundle. So you'd want to make sure you're clear on that. Take total joints for example. Is there post-op therapy included or not included? Would be a common thing to see, both ways. Sometimes it's included, sometimes it isn't. But otherwise, yeah, I think to Chip's point, I think the greatest thing about bundles, it creates the transparency and frankly, more of a free market.
Great. Thank you. The next question, what is the most difficult step in setting up a bundled payment program for employers? And Josh, maybe you want to start, and then Chip and Troy, you could weigh in on this as well.
Yeah, I think it's pretty simple. It sounds complicated. It sounds like it's going to be a lot of work, and it can scare employers from going down the path of creating a plan design or some form of a cash incentive. And the reality is, if you partner with the right TPA who can support your plan design, whether it's a 3-tiered plan design like we showed in the slides previously, or if it's a standalone cash incentive, trip incentive, et cetera, it's really just about getting over the hurdle of the concern of the amount of extra work and the ability for your partner to be able to administer it and effectively communicate it to your health plan participants. We have almost 40 years of experience in both PPO contracting and health plan administration, and it's something that we're very specialized in. So if you partner with a TPA like Health Easy, we will make it easy.
Oh, nice tagline there at the end, Josh.
I have to. Every time I'm on a webinar, I've got to make sure we tagline in about Health Easy.
Yeah, I mean, the only comment I'd make about it related to, obviously the provider has some work to do as it relates to bundle it and coordination of the care and the outcomes and making sure it's safe, et cetera. A lot of the challenge that we've seen is it's different on the payer side. So it's not a fee for service type structure. So at the very, very granular level, they struggle on how to actually pay a bundle claim. So that many times is the biggest hurdle. And to Josh's point, working with what I'd call more of an independent TPA is you've got a lot more autonomy and can be a lot more creative and innovative.
Yeah, I agree with all that. Our biggest struggle is administration. We need eligibility data. We need out-of-pocket information for the plan member that's going to come from the TPA. And Troy, you're right. The ability to basically we submit a single bill with the bundled rate, and the carriers especially don't have their claim systems just have real difficulty accommodating that. So we found much better success with third-party administrators that can be innovative and flexible in that piece of it. Interestingly, contracting with providers, and certainly the Twin Cities is unique because of TCO being such a leader, but in other markets, surgeons and surgical groups are very interested in bundles. And if they're invested in a surgery center, it's pretty easy. Trying to work with hospitals on bundles, that is, again, pretty hard work to make that work.
Yeah, I would just echo that is completely accurate. We've had a lot of success in working with ambulatory surgical centers in different markets outside of Minnesota, and they are, very willing to engage in these type of arrangements. Hospitals are definitely much more reluctant to do a bundled payment arrangement.
Great, thank you. One last question here, and I guess I would ask anybody who's on the panel to chime in. Do you have any reported savings from the employers who have implemented the high value approach versus what they were standardly doing, whether it's a percentage or something that you want to weigh in on here?
Yeah, as I mentioned, that one employer, sorry, Josh, that one employer in Monterey County, $14,000 a case, And again, that's on a wide range of procedures. So we've got, $5,000 knee scopes included in that, and $20,000 total hips, $30,000 spine surgeries, but averaging out at $14,000 a case. And I think that's pretty typical. If the program's limited to high acuity, certainly the savings per case are going to be higher.
Yeah, we actually here in the Twin Cities have clients that are using our elite network, and we have an employer that has about a third of their population is in the elite network, and 2/3 of their population is not. In that elite network, that's focused on high quality, lower cost providers as well as bundled arrangements, is coming back on a PEPM basis at 50% of the spend of the other two plans. So if you can incent, put them in a appropriate network with the right providers, you can have tremendous savings.
Great. Troy, anything to add? Any final comments?
No, I mean, I think, Josh summed it up well there from a standpoint of we look at obviously at a episode level, not at the grander health plan level, but I think anything employers can do to start aligning those incentives to kind of go back to that. And frankly, part of that aligning incentives is educating your plan members and creating those incentives. And I think Chip and Josh did a great job of there's all kinds of ways to do it, from, the almighty dollar to time off. There's all kinds of ways to incent the individuals to help. And it's really about educating them to make the right decision is ultimately should be the focus.
Great, thank you. Well, we are right up against the hour. Thank you to everyone who has participated, all of our expert panelists for the series. It's been our pleasure to co-host this important series with Twin Cities Orthopedics. And we also want to thank our sponsors, AccuRisk Solutions and Nationwide Insurance. So stay tuned for future webinar announcements. Thank you, everyone.
That concludes today's presentation. On behalf of the presenters and Health Easy, thank you for joining.